Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. Today, we're going to be led by Dr. John Kim, periodontist from Rocky Mount, North Carolina. And we have a team of specialists from all over the country that are going to work in an interdisciplinary fashion. Orthodontist Rick Robley, Alan Jerem, restorative Prost Digital, Stanislavi Mishi, prosthodontist, and myself, prosthodontist, to weigh in on these interdisciplinary cases so that we can give our point of view, just what needs to happen in our own clinical practice. Dr. John Kim, let's take it away.
Thanks a lot for that introduction. And I do look forward to sharing my case about Haiti, as I found this case to be quite complex, and I look forward to learning from all of you and seeing how to best treat her. Haiti is a very sweet lady, referred to me for 2 dental implants. And when asked why she was seeing me, she responded that I want dental implants pretty much for number 8 and 10 area. She's already missing number 10, and she's about to lose number 8. And she did mention to me that cost is a very big concern, like it is with many patients that I do see. As beauty is in the eye of the beholder, simply filling in the gaps with teeth was going to be enough for Haiti. She wasn't really looking for a quote unquote the Hollywood smile. Regarding her medical history, she's suffering from depression and deals with higher anxiety. Her over the counter meds have been enough to help her with managing her osteoarthritis. She takes Flexeril for her back spasms. From a dental medical relationship or standpoint, I believe that her anxiety has contributed to her lack of regular dental care. I also think that her acid reflux has contributed to some of her current dental problems. And as a surgeon, it's important for us as surgeons to take into consideration her penicillin allergy, as taking an alternative antibiotic has been associated with a higher complication and infection rate. Haiti said that she lost most of her teeth in the past due to cavities, some of which were secondary to her erosion from acid reflux. While she currently wears her mandibular partial denture, she has not and still does not wear her maxillary prosthesis. The main reason that she was referred was to have 2 dental implants, as number 8 recently fractured. Prior to number 8 fracturing, number 8 and 9 were splinted crowns. Now she has a temporary for number 8. Here is a full mouth series, and it shows that Haiti has had extensive restorative work along with a full root canal treated teeth. From a periodontal standpoint, I look at this and I don't really hit the panic button. She does have some mild to moderate horizontal bone loss present, more so in the mandibular anterior, but not too concerning when I put it together with what I saw in the periodontal examination. I did take a CBCT, as she was referred to me to treatment plan for dental implants. And regarding number 8, Haiti's really hoping to have a dental implant. The facial and palatal bone are intact, and I believe that if we do place an implant, an immediate is definitely possible. Number 10 has significant horizontal ridge deficiency. So if we are to place an implant for number 10, this would require a ridge augmentation procedure, which would require a longer healing time. I don't feel like this is one that I would do a simultaneous approach. I'd take the stage approach, that is, do the horizontal ridge augmentation or GBR, let it heal for 6 to 8 months, and then proceed with implant therapy. Another thing to look at here is that she does have a slightly pneumatized sinus, so that if we are to do implants in the posterior, she may need some sinus augmentation procedures. We took some digital impressions with our Trio scanner. Since she does not wear her maxillary valvoplast, her lack of posterior stops has caused her incisors to procline. You could really appreciate looking here, seeing the flaring and the spacing seen on the anterior teeth and the knife edge ridge in the posterior mandible. She's class 2 canine on the left and class 3 canine on the right, leading to her significant midline deviation. She also has a deep bite. Super eruption has caused a cant down on the right. She has mild to moderate lower anterior crowding present. On the periodontal examination, it revealed that she had no deep probing depths that I was concerned about. She has a good band of keratinized tissue and therefore does not have many areas with inadequate attached gingiva, other than maybe in the mandibular teeth, particularly in the mandibular anterior region. The main concern I see is that she does have generalized teeth mobility and more so in the anterior teeth. So she is a successfully treated stable periodontitis patient. That's the diagnosis. When I was in residency, 15 plus years ago, we call this periodontal health on a reduced periodontium, meaning that her periodontal health is now stable, but she does have a history of past bone loss, likely due to periodontitis. She does have minimal gingival recession for number 20, lack of adequate attached gingiva for the mandibular teeth, minimal keratinized tissue in the mandibular arch, and there are a few areas of minimal gingival pigmentation, nothing of much that concerns Haiti. And as you saw earlier, and it's harder to see here, but there is a horizontal and vertical ridge deficiency in the edentulous sites. With regards to the facial analysis, the interpupillary line is canted left. You could see with the blue line that the midline of teeth is right relative to the center of her face. Her upper and lower lips are thin and retruded. Profile wise, I thought she was more so straight to convex or had a straight to convex profile. Lips are mildly protrusive to the E line, and she has a poor neck throat form. Her deep bite is causing her to have a short lower one third of her face. She has a high smile line present with excessive display of gingiva, more noted on the right side up until number 11. There is a larger buccal corridor space present. And when in full smile, it looks like Haiti shows about 12 teeth. With a maxillary vertical discrepancy, the left side is higher than the right side. There are uneven gingival zenith. What is particularly striking is a gingival margin discrepancy for number 8, 9, 6, 11. And because of the unilateral bite collapse, the axial inclination, the embrasures, and the contacts are off. As this case is very complex, I really struggled with coming up with an ideal treatment plan. Here are a few thoughts that came across my mind. Do we consider orthognathic surgery? I can't imagine treating Haiti successfully without having orthodontics involved. Would having TADS or anchorage device help, or is it asking too much to fix the severe cant that's present? Should we consider placing an implant in the mandibular first molar site for anchorage and possibly let it become a future crown in later on? If we can open her bite, that is increase her VDO, then I think that implant therapy for her chief complaint, that is getting 8 and 10, is certainly a possibility, but I don't think so at this state she's in right now. And if she does have some dental implants, it's for sure that other than number 8, Haiti will require some significant ridge augmentation procedures. I really do think that Haiti would benefit with an occlusal bite guard and also be on a close 3-month recall program due to the complexity of this case and how much work may be required. So, as finance is a limiting factor for Haiti, I know that much of what I just proposed in the ideal treatment plan is likely not possible for her. And she indicated to me that she would really prefer not to be in braces, saying that she's too old. This leaves us to removable prosthesis as our likely treatment plan. Me personally, I don't feel comfortable placing implants where there's inadequate spacing available. And in designing the maxillary partial denture, would it be helpful to have an anterior bite stop to help open her bite just enough and to give her lower anterior teeth a stable stop? And this is a very challenging case. And this is a case, actually, I was very excited about this date coming about because I cannot wait to hear what everyone here in this table has to say and how to treat Miss Haiti. I'd love to hear what you have to say now.
What's so interesting about bringing us all together, it really shows the need for everybody's point of view from a periodontal standpoint, from an orthodontic standpoint, from a prosthodontic standpoint. Us, the let's call the pros team. Somebody's got to be a little bit of that captain, and I've always said, sorry everybody else, that the captain has to visualize where we're going and bring in your colleagues to help you figure out how do you get there. But if we visualized where she should go with just a basic diagnostic wax up at a proper vertical dimension of occlusion that created a proper overbite and overjet, which we call 4 millimeters of overbite and 2 millimeters of overjet in the biological model, at that vertical dimension with posterior verticalizing stops, that's your wax up. So if we can visualize where we want to go, we can even take that wax up, turn it into a 3D, an impression stone. Now we do 3D printed models, but turn that into a mock-up if we wanted to show her, kind of this improvement. But the bottom line is once we know where we're going, it's just working backwards, and it's utilizing all of your data points, which is, treatment plan presentation. Here's one option. Here's a second option, which could be, okay, we're not doing implants, implant supported, crown and bridge, periodontal status. We got a good report. That's great. Orthodontics, we might need to move some teeth before to create the implant space. Ideal treatment plan. Patient says, let's say we can't afford it. So, right down the line, we look at these other options, and they can be in removable partial dentures as either an interim step or a permanent step. And, home care and periodontal status and oversight, I should say, and continuous care is so critical. So I'm gonna hit the pause button, but I always go, here's where we are. This is where we want to get to. And, in our own practice, we have these kind of interdisciplinaries where we all get on a Zoom call and look at the cases together. It allows all of us right now to be seeing the same thing and sharing point of view. So I'm going to pause and I pass it over to my teammates.
I can add to the conversation as well. I can't agree, Dr. Kim, more with your statement that this is not a case where we have to fill in the spaces. This is a prosthodontic case. We see a lot of this condition in many patients, unfortunately, due to lack of care for many years. Mm-hmm. So what I can see on this slide is that it appears this patient has moved the mandible and trying to bite in a habitual position, which is to the left, where are the only contacts that she can find between her upper and lower teeth, as minimal as they are. So as Dr. Levine said, we have to first do our wax up. We have to put the patient in a position that's repeatable, a position that's stable, that doesn't stretch the muscles or the ligaments, doesn't put any strains and stresses on the joint. So hopefully there's no already any permanent damage occurred for this patient. So we will have to do some imaging. But yes, first step would be to put the patient in an occlusion that should be more comfortable for her, and then go ahead with all our aesthetic evaluation, build up the occlusion, build up the aesthetics, and figure out how to get there, whether it's through orthodontics, whether it's through more extractions, whether it's through removable prosthesis, which could be the reality for this patient. But if we determine her positions and give her stable occlusion, there's nothing wrong with partial dentures as long as we have a stable occlusion.
Yeah, I think it's a really great case where it shows, when you're trying to generate a plan, interdisciplinary, thinking about what is best for the patient, and then living in reality where most patients are going to be limited by finances. It's a question of, determining, to visualize, like Jonathan said, where do we want to go with the case? And then we have to figure out what we think is the best solution for that patient with some of the limiting factors that we may have. And a lot of times when we see cases like this, what we're beginning to present to the patient is, when we hear that they say that finances are going to limit their treatment, we try to explain to them that just means that you need a plan which is over a longer period of time. And we still have to put together a plan that's going to try to address the same issues that we've identified as we were identifying the main issues. We just have to find a way where we can do this over more time so that we can hopefully put together something that's realistic for the patient. And I think it's a common limitation that could sometimes be overlooked when we figure the ideal out, and then we have to try to tailor that back, and we have to try to figure out how we're going to tailor it back so that the patient can do some of the work with hopefully taking one step forward and not taking a couple steps backwards if they can't proceed with the ideal plan over time.
Exactly. Many times it's a matter of phasing the treatment.
Yeah.
We always tell the patient we can upgrade gradually to the ideal fixed restorations that you're looking for. But even if we do it today, or if we do it 3 years from now and we stage it, we still have to go through the same evaluations and the same steps of stabilizing the occlusion.
I think also the tools that we have that where we can better share that visualization with the patient, just as we're talking about motivational mock-ups and how that helps with aesthetically driven patients, the same idea has to be shared with patients in this scenario so that the better they understand that long-term plan, the more empowered they're going to be to try to stay with that plan and not just get through phase one and then the patient trails off and then all the work up to that date may become inaccurate, So those tools also help engage the patient to understand that a long phased plan is still the best option and engages the patient into that treatment plan better. Their understanding is better with it.
Yeah, it's so true. What great points you're making. And I love the point of, thinking creatively and coming up with these other options. Not everybody can accept, afford, or whatever's in their head about this ideal treatment plan. But if we think creatively, a lot of times we really could get them on the road to improvement, get them into a holding pattern on one arch as we go to the other arch, just like Stanislava, Dr. Mishi was saying, where we really can time things and we fit into everybody's, either their lifestyle, their budget, their financials, with a mindset that we want to help people. I mean, I just think there's so many creative options we can also have. Dr. Robley, love to hear your thoughts.
Yes, interesting case and very real world. And certainly, Jonathan, you and I are probably the only ones on this panel that can remember days before implants. Okay, and what would you do with it? Okay, and that's a huge deal. But some of my philosophy at this point, and as an orthodontist, I see these kind of patients all the time. And, and whenever I hear the patient just wasn't interested in orthodontics, I say the practitioner usually wasn't interested in orthodontics. I'll be honest with you, because that is so true.
So true.
And so a couple different things, my team, our interdisciplinary approach, we always come up with 3 treatment plans. The first is interdisciplinary ideal. If we had anything we could do, what would it be? If you don't start there, you'll never get there. The second one is where we live most of the time is what we call interdisciplinary alternatives. That's where you have a great interdisciplinary team and you can bend the rules a little bit very scientifically with great results, great longevity. And, that's what most of our treatment, because ideal sometimes is over treatment. But then there's a third one. If option 1 or 2 isn't available, we do interdisciplinary phasing. And she is a classic interdisciplinary phasing. And I think removable appliances are an acceptable option for her as a very short term to make her feel better. But as we know, removable appliances in a case like this are a means to slowly extract teeth to get her into fully edentulous. And so, my goal would be to educate her, get her motivated towards treatment. Most of her teeth are stable. Get something removable in there that's going to do that interdisciplinary phasing. And then plan on placing strategic implants to reestablish the infrastructure and slowly rebuild her over time. And I think that would be by far the best option, because if you get some anchorage, reestablish occlusion, the world has all kinds of different alternatives, whether it be orthodontics with different treatment modalities that we can work patients in. The key to an interdisciplinary team is not a one-time thing and get it done. It's a lifelong journey. And what we need to do is make it within that patient's means and interest to get them where they're going to go. And so I think this is a classic example of that in a very interesting case, but very real world.
Yes, I agree. And also, to your point, Dr. Roble, by placing strategic implants in certain areas to help us with the orthodontic movement, at that point, we can always pause the fixed treatment and use implant-assisted partial dentures for the time being to minimize cost, and then upgrade with more implants and more fixed restorations slowly, whether it's finish one arch first or one side or whatever patient can afford to do. But absolutely, implants open so much world of opportunity for us.
Absolutely.
I can't believe how great this group is. Rick Robley, I want to make this protocol for us for thinking about our presentations. The way you just laid this out, I have never heard that before. Interdisciplinary ideal, interdisciplinary alternatives, interdisciplinary phasing. So if we all thought like that, honestly, I don't think we'd ever lose a patient due to financial reasons. There's always going to be a way to hold them over, but you're codifying through 3 phases. How can we help you in all of these different options? I think we're just going to make it. We have to make it a protocol of this group. I think it's just fantastic, and it's why I love our profession, because we're always learning. I mean, I never knew that. In my head, I thought about options and choices, but I just think it's fantastic. Thank you so much, Rick.
Thank you. Thank you, everybody. This is a great case.
Unbelievable. So exciting. John, Dr. Kim, thank you so much for bringing this case. It's exactly what people are saying. It's the real world case. And it shows, as the periodontist, that is so important from an infrastructure standpoint. And with our restorative ortho is where we have to lean in for even cases that don't even look that complicated. It reminds me of my old pathology professor. The eyes do not see what the mind doesn't know. We see simple, everything's fine. Yeah, but meanwhile, they got wear on their canines, bouncing interference on the opposite side. And 3 years later, when they walk in, they're a millimeter short of enamel on their anterior teeth. And we could have restored with composite the canines and put them in a night guard, as an example. So we need to be dental detectives. And it's only through this team approach, this collaboration, that really happens. It's very exciting.
Mm-hmm.
Well,
I'll say that this case was
John, please.
I'll say that this case was challenging from a patient management standpoint. She might have not been as well prepared for the examination, in my opinion. It's just she came in with the mindset of, I'm going to see Dr. Kim, and he's going to get me scheduled to have 2 dental implants, and I'll be done. And when I sort of laid it out to her that that's not going to be the way we can go. I mean, I love implant therapy. It's my bread and butter of my practice, and I do it all the time. She was in tears. And so it's just one of those things. It's always about prepping the patients as much as possible. More so almost not getting cornered into doing one treatment, keeping them open-minded. And as everyone had mentioned here, you got to begin with an end in mind and know that we might not get there as soon as the patient would like.
You hit a very important point, Dr. Kim. Unfortunately, I believe education, dental patient education is what we need to also perform a lot in our practices. Our patients very commonly come with just requesting to restore those anterior missing teeth and completely unaware of what is happening in the back of their mouth, and trying to convince us how important it is the front and how unimportant is the back of their mouths. And that kind of education is lacking in the public, and it's our job to do that. We know that anterior restorations are not going to last if we don't have posterior support. So,
well, I'm going to weigh in a little bit on that. I hope I don't ruffle any feathers, but the world of cosmetic dentistry without an interdisciplinary approach,
oh gosh, it's crazy.
Can be a little bit problematic. Mm-hmm. And I say that cosmetic dentistry, meeting the needs of the patients. Yes, everybody wants to have a beautiful smile, but the structure, function, biology has to be there. You can lead with aesthetics, but you need to have that understanding, those fundamentals.
Or it won't be there in 30 years.
Very good point.
There we go. There we go. All right, let's end it on that note. That's a great note, and let's bring it around. Case Bites, great episode, unbelievable. Thank you, Dr. John Kim. Thank you, Dr. Rick Robley. Thank you, Dr. Alan Jerem, and thank you, Dr. Stanislav Amishi. You guys are amazing, and it is so much fun to do this with you. Thank you for joining us for Case Bites. If you haven't already, please subscribe to the series to receive a new case in your inbox every week.